Dr. Frank Hu is the chair of the Department of Nutrition, Frederick J. Stair Professor of Nutrition and Epidemiology at Harvard T.H. Chan School of Public Health and Professor of Medicine at Harvard Medical School and Brigham and Women's Hospital. He serves as the co-director of the program in obesity, epidemiology, and prevention at Harvard and director of Boston Nutrition and Obesity Research Center Epidemiology and Genetics Core. His major research interests include epidemiology and prevention of cardiometabolic disease through diet and lifestyle, gene-environment interactions and risk of obesity and type 2 diabetes, nutritional metabolomics in type 2 diabetes and cardiovascular disease. He served on the Institute of Medicine Committee on Preventing the Global Epidemic of Cardiovascular Disease, the AHA-ACC Obesity Guideline Expert Panel, and the 2015 Dietary Guidelines Advisory Committee, USDA and HHS. He has served on the editorial boards of Lancet Diabetes and Endocrinology, Diabetes Care, and Clinical Chemistry. Dr. Hu is a member of the National Academy of Medicine. We look forward to your talk today. It's always insightful to hear your wisdom. Thank you.
Thank you, Michael, for the kind introduction and also for inviting me to give this grant rounds. Let me share my screen. Okay, can you see it?
Yes, yeah, looks good.
Okay, so this morning I'm going to talk about regular coffee consumption for chronic disease prevention and longevity. Is this too good to be true? And I know that many people already had your morning coffee or is drinking coffee as we speak. But the question is whether coffee is really good for you in terms of health outcomes. There has been a lot of controversy regarding the relationship between coffee consumption and some of the health risks, especially some cancers and pregnancy-related outcomes and so on and so forth. So today I'm going to give you an overview on the current evidence regarding coffee consumption and a wide range of chronic diseases and also pregnancy-related outcomes. Recently, my colleagues, Rob Van Dam, Walt Willett, and I published a review paper on coffee, caffeine, and health in New England Journal of Medicine. The purpose of this paper is to review current evidence on a complex relationship between consumption of coffee, caffeine, and wide range of health outcomes and make recommendations for clinicians, nutritional professionals, and also the general public regarding coffee and caffeine consumption. So where do we get caffeine? Most of the caffeine in our diet come from coffee. So 1 12-ounce of coffee contains about 100 to 200 milligrams of caffeine. Some coffee types have much lower amount of caffeine, such as instant coffee, espressos, has less than 1/2 or even 1/3 of the caffeine compared to regular coffee. Tea has much lower amount of caffeine than coffee. So for example, black tea contains about only 50 milligrams of caffeine, and the green tea contains only about 28 milligrams of caffeine. But some commercial products, especially over-the-counter energy shots, have very high amount of caffeine. For example, energy shots, 2 fluid ounce of energy shots contains 200 milligrams of caffeine. For young people, especially teenagers, their caffeine intake come from three main sources: coffee, tea, and soft drinks. Soft drinks is actually the primary source of caffeine intake among individuals of 15 to 19 years old. For middle-aged adults, 2/3 of caffeine come from coffee, and 16% from tea, and another 16% from soft drinks. Both coffee and caffeine have a wide range of biological effects on our tissues and organs. So in terms of brain health, we know that caffeine increase mental performance and increase alertness and vigilance. And that's why so many people love coffee first thing in the morning. But too much caffeine can also contribute to insomnia and induce anxiety. In terms of the effects on the lung, it has been shown that caffeine is effective for treating apnea of prematurity in infants. In adults, caffeine has been shown to slightly improve lung function. Both coffee and caffeine have wide range of beneficial effects on liver health. I'm going to talk about the evidence later, but studies have shown that coffee and caffeine intake may reduce the risk of liver fibrosis, cirrhosis, and even liver cancer. High dose of caffeine has been shown to have diuretic effects, but habitual moderate intake does not substantially affect hydration status or kidney function. In terms of cardiovascular effects, it is known that caffeine intake increases blood pressure in the short term, but many people develop tolerance with habitual intake. This is the same for the endocrine effect. Acute caffeine intake reduces skeletal muscle insulin sensitivity in the short term, but again, tolerance can develop with habitual long-term intake. As I mentioned earlier, caffeine may have adverse effects on reproductive health, and studies have shown that overconsumption of caffeine may reduce fetal growth and increase the risk of pregnancy loss. In the past several decades, we have conducted extensive analysis on the relationship between consumption of coffee and caffeine and wide range of chronic diseases and also mortality. So those data are based on our three large cohort studies: the Nurses' Health Study, Nurses' Health Study 2, and the Health Professional Follow-up Study. And in those cohorts, we have collected detailed data on diet and lifestyle every 2 to 4 years in the past 4 decades among almost 300,000 nurses and health professionals in the US. So the detailed data on diet, including coffee and caffeine intake, have allowed us to conduct a comprehensive analysis on the relationship between coffee and caffeine intake and the various health outcomes. So in our cohorts, we have analyzed coffee intake and the risk of type 2 diabetes, CVD, gallstone disease, gout, Parkinson's disease, depression, suicide, some cancers, cognitive function, and premature deaths. I don't have time to present detailed results for each of those outcomes, but I'm going to present meta-analysis, the results from meta-analysis of not just including our cohort and many other cohorts from other populations to give you summary estimates regarding the effects of coffee on those health outcomes. So this is a meta-analysis published in BMJ in 2017. This figure shows beneficial health outcomes associated with higher coffee consumption. So higher coffee consumption has been associated with lower risk of developing type 2 diabetes, cirrhosis, Parkinson's disease, post-MI, mortality, gout, liver cancer, and chronic liver disease. As you can see that some of the meta-analysis, the outcomes were based on only 2 or 3 studies, but for liver outcomes and also for type 2 diabetes, the number of studies is much larger, especially for type 2 diabetes. So far, almost 30 large cohort studies have examined the relationship between coffee consumption and the risk of diabetes. And the results have been remarkably consistent. Almost all the studies have shown that increasing coffee consumption is associated with a lower risk of developing diabetes. Those are the harmful outcomes that have been associated with regular consumption of coffee. And most of the harmful outcomes are related to pregnancy related outcomes, such as premature birth and low birth weight and so on and so forth. As you can see that the confidence intervals for those estimates are pretty wide, and indicating that the results are not very robust. And also for cancer outcomes, some of the associations are significantly positive. However, again, the confidence intervals are pretty wide, indicating that those results are not very stable. So for cancer outcomes, I think it's very important to consider the confounding effects of cigarette smoking, because people who drink a lot of coffee tend to smoke. And for lung cancer, we and others have found that the significant positive associations between coffee consumption and lung cancer become non-significant when the analysis were restricted to lung smokers. So it means that some of the positive associations observed between coffee and cancer outcomes is likely to be due to confounding by cigarette smoking. For pregnancy-related outcomes, the observed adverse effects are most likely due to high consumption of caffeine rather than coffee. And so that's why nutritional guidelines have recommended that pregnant women should reduce intake of their caffeine to a relatively low level, no more than 200 milligram per day. A controversy erupted in California a couple of years ago when the government required coffee shops to put a warning label, cancer warning labels on coffee cups. The reason for this requirement is because of this compound called acrylamide. And this compound, chemical compound, is formed during high temperature cooking of many foods, including roasting of coffee beans. In animal studies, very high dose of acrylamide has been shown to induce tumors in animals, but this exposure in animal models is 1,000 to 10,000 times greater than dietary exposure in humans. So the animal data may not be relevant to coffee consumption in human populations. In the Nurses' Health Study, we look at different food sources of acrylamide intake. So French fries contribute about 23% of acrylamide. and coffee is about 13%, breakfast cereal is about 12%. And so as you can see that most of the acrylamide come from carbohydrate containing foods, and coffee contribute only a small proportion of acrylamide in the US diet. In the Nurses Health Study, we look at the relationship between acrylamide and the risk of breast cancer and other cancers. We measured acrylamide intake using food frequency questionnaire, and we also measured biomarkers of acrylamide intake in the blood. And we found no significant association between either acrylamide intake or biomarkers of acrylamide intake and the risk of breast cancer or other cancers. Likewise, a comprehensive review by the International Agency for Research on Cancer, or ERIC, found no evidence between coffee consumption or acrylamide consumption and the increased risk of a wide range of cancers. Of course, coffee is not equivalent to caffeine because coffee contains numerous bioactive compounds which may have different effects on health from caffeine. And some of those compounds may counterbalance the potential harmful effects of caffeine on certain cardiometabolic outcomes, such as increased blood pressure or increased insulin resistance. So the question is, does decaffeinated coffee have the same health benefit as regular coffee? So in the BMJ meta-analysis, they also look at the relationship between decaffeinated coffee and various health outcomes. As you can see here, most of the outcomes are not statistically significant, but there is an indication that higher consumption of decaffeinated coffee is also associated with the lower risk of developing type 2 diabetes and endometrial cancer. Of course, because the consumption of decaffeinated coffee is much lower than regular coffee, so the statistical power to examine the relationship between decaffeinated coffee and the health outcomes is much lower compared to the analysis on regular coffee. Nevertheless, it looks like for some of the outcomes, especially type 2 diabetes, both regular coffee and decaffeinated coffee have similar beneficial effects. Several large cohort studies have looked at the relationship between coffee consumption and mortality. In 2015, we conducted analysis on this relationship among 200,000 men and women in the Nurses Health Study cohorts and health professional follow-up study. We found overall inverse association between coffee consumption and mortality, and this relationship is stronger among never smokers than current smokers. We found similar benefits for regular coffee and decaffeinated coffee. So this figure shows the relationship between total coffee consumption, caffeinated coffee consumption, and decaffeinated coffee consumption, and total mortality. So the black line shows the relationship for the whole population, and the red line shows the association for never smokers. So as you can see that for the overall cohort population, there is a kind of U-shaped relationship between increasing consumption of coffee and mortality. So the lowest mortality was found among those who consume 3 cups of coffee per day. However, when the analysis was confined to never smokers, the U-shaped relationship disappeared, and looks like there is a dose-response relationship between increasing consumption and a lower risk of mortality, and the mortality risk continued to decrease even among those who consume 4 to 5 cups of coffee per day. And for decaffeinated coffee, because the consumption is pretty low, so we can only look at those who consume 1 to 2 cups of decaffeinated coffee per day. And here you can see that there is a significant relationship, inverse association. And cigarette smoking did not modify this relationship because smoking is not associated with decaffeinated coffee consumption. This is an analysis based on more than 500,000 participants in the European prospective investigation into cancer and nutrition cohort, or the EPIC cohort. Similar to what we found in our cohorts. In the EPIC study, regular consumption of coffee is associated with total mortality and also cause-specific mortality. And they found similar association with caffeinated and decaffeinated coffee. And they also found that coffee consumption associated with reduced insulin resistance, systemic inflammation, and biomarkers of the liver function. This is an analysis from the multi-ethnic cohort, which has followed more than 185,000 African Americans, Native Hawaiians, Japanese Americans, Latinos, and whites for 16 years. Again, they found that 4 or more cups per day of coffee is associated with 18% lower mortality risk. And the results are largely consistent across different racial and ethnic groups. And also, there is a significant benefit for moderate coffee consumption in terms of cause-specific mortality, including mortality from heart disease, cancer, chronic respiratory disease, diabetes, kidney disease, and so on and so forth. This is an analysis of more than 400,000 older adults from NCI cohort. It's called AARP cohort. Similar to the data from other cohorts, higher coffee consumption is actually associated with unhealthy lifestyle factors, such as smoking, excessive alcohol consumption, higher consumption of red meat, and lower consumption of fruits and vegetables, and less physical activity. So after adjusting for those confounding factors, there is a dose response inverse association with total mortality. Men who consume 6 or more cups of coffee per day had 10% lower risk of death compared to those who didn't drink coffee. And the association was slightly stronger for women. Again, inverse association was found for different causes of death. Recently, the UK Biobank published an analysis on coffee consumption and all-cause mortality. So the UK Biobank includes more than 500,000 participants from the UK. They have been followed for more than 10 years. And similar to what had been observed in other cohorts, coffee consumption was associated with lower mortality. And for this cohort, they were able to look at much higher levels of consumption, like 7 or 8 more cups per day. And they didn't find increased mortality among heavy consumers. Instead, they found an inverse association even for those who consume 8 or more cups per day. And they also found inverse association for different types of coffee beverages, different type of coffees, like ground coffee and instant coffee, even though the association for instant coffee was weaker. And they also found that common genetic variants for caffeine metabolism did not modify the associations between coffee consumption and mortality. It means that the inverse association between coffee consumption and mortality was independent of caffeine metabolism genotypes. Again, they found similar associations for caffeinated and decaffeinated coffee further suggesting the importance of non-caffeine compounds in this inverse association. Many studies have looked at the relationship between coffee and neurodegenerative diseases. I think the most consistent finding is the inverse association between coffee or caffeine consumption and Parkinson's disease. For Alzheimer's disease, there is also a significant reduction in risk for higher coffee consumers, but the results are not very consistent for other brain health related outcomes, such as cognitive decline or dementia. In our cohorts, we found a strong inverse association between increasing coffee consumption and the lower risk of depression. And we also found that people who consume coffee regularly had significantly lower risk of suicide. And the beneficial effects of coffee on mental health related outcomes are likely to be driven by caffeine rather than other components of coffee. However, it's very difficult to tease out the independent effects of different components of coffee because they all come together in a complex beverage. So in epidemiological studies, it is impossible to separate the effects of different compounds in coffee. So we know that coffee contains high amount of polyphenols, especially chlorogenic acid, and those polyphenols have very strong antioxidant, anti-inflammatory properties. Chlorogenic acid is associated with improvement in glucose metabolism and blood pressure regulation. And caffeine itself has antioxidant effects and potential neuroprotective actions and the psychostimulant effects, and also potential antidepressant and antifibrotic properties. Other components of coffee, such as magnesium, tricholinane, have been shown to improve insulin sensitivity. And terpenes in coffee have been shown to have potential anti-carcinogenic effects, but they also have cholesterol raising effects. So for cancer outcomes, the potential bioactive compounds are most likely include terpenes, mannanoidins, and polyphenols, which all have been shown to have antioxidant effects. For metabolic and cardiovascular outcomes, polyphenols, especially chlorogenic acid, and have been shown to improve insulin sensitivity and reduce chronic inflammation. And lignans, one type of polyphenols in coffee, and a higher amount of lignans have been shown to reduce insulin resistance and have been associated with lower risk of developing type 2 diabetes. For mental health and neurodegenerative outcomes, the most likely contributor to those benefits is caffeine, because we know that caffeine has neurostimulative effects and has been shown to reduce depression and reduce the risk of Parkinson's disease. For liver health, the benefits are most likely due to the combination of caffeine and also polyphenols, because caffeine may counteract the fibronic effects of in the liver, and also the polyphenols have been shown to have antioxidant effects that may reduce inflammation in liver. So it seems that for different outcomes, different components of coffee or combinations of different components of coffee may explain the beneficial effects that have been observed in various epidemiological and clinical studies. as I mentioned earlier, one of the compounds, one class of compounds in coffee, terpenes, may have anti-cancer effects, but those compounds also raise LDL cholesterol. So if you drink unfiltered coffee like French press or Turkish coffee, it's likely that regular consumption may increase your total and LDL cholesterol. So for people who want to manage their cholesterol or want to have better control their LDL cholesterol, it's better to drink unfiltered coffee instead of regular filtered. It's better to drink filtered coffee instead of unfiltered coffee. Recent evidence from human and animal studies have shown that coffee consumption may improve gut microbiome, and we know that the gut bacteria are involved in the biotransformation of polyphenols in coffee, and that can lead to additional antioxidant effects. And I think this is really a fascinating area for research. And recently we measured gut microbiota metabolites from coffee, and we found that those metabolites, higher concentration of those metabolites in urine or blood associated with lower risk of developing type 2 diabetes. In this study we published recently in Diabetes Care, we conducted metabolomics profiling of several thousand, 1,500 nurses participants, and our goal was to identify metabolomic signature of coffee consumption, and we found that 34 plasma metabolites were associated with coffee consumption, 13 metabolites associated with increased consumption, and 21 was associated with lower consumption. So for the positive metabolites, those are mostly polyphenol metabolites or caffeine metabolites. And those metabolites are associated with lower risk of developing type 2 diabetes. Adding those metabolites to a classic risk factor based type 2 diabetes prediction model significantly improve the statistics or the prediction of future risk of developing type 2 diabetes. So this study suggests that those metabolites can be used as the biomarkers of to assess adherence to coffee consumption or response to metabolic response to coffee consumption, and measure those metabolites in urine or plasma samples can identify individuals may benefit from increased or decreased coffee consumption in terms of reducing risk of type 2 diabetes. Of course, all the data that I have presented from epidemiological studies need to be interpreted in the context of limitations of epidemiological studies. And the main concern about observational analysis is confounding, even though all the cohort studies have controlled for a wide range of behavior, dietary, socioeconomic, and health-related factors. There is always an issue of residual confounding or unmeasured confounding. However, because coffee consumption is typically associated with unhealthy diet and lifestyle factors, so any residual confounding is likely to bias the results toward a positive association between coffee and health risks rather than an inverse association that has been observed. So it means that if the residual confounding could be completely eliminated, the inverse association observed in the epidemiological studies might have been even stronger. And another limitation is that coffee consumption, the data on coffee consumption were collected using self-reported methods, especially food frequency questionnaires. So in self-reported dietary assessment, measurement error is always inevitable. However, compared to other dietary factors, the measurement of coffee is much, much better. So I'm going to come back to that in a few seconds. And another issue is that coffee is a complex beverage. There is a wide variability in caffeine and bioactive compounds in different types of coffee, depending on the types of coffee beans, and also roasting methods and temperature. And some compounds have opposing health effects, as I mentioned earlier. The ditterpenes may have anti-cancer effects, but they also increase your total and LDL cholesterol. And another limitation in the observational analysis is that people may change their coffee intake behavior because of their health conditions. So some people may stop drinking coffee after they develop certain health conditions. But the epidemiological studies of coffee also have many strengths. So in most situations, it's infeasible to conduct large RCTs, especially for coffee, and health outcomes. It takes many years and also hundreds, thousands of individuals to look at coffee consumption and risk of chronic diseases. So this kind of studies is not feasible. So in the absence of long-term large RCTs, the observation evidence from large cohort studies, I think, is the best available evidence on this relationship. So I have presented findings from many different populations and different ethnic groups, racial and ethnic groups, and the results have been remarkably consistent. And as I just mentioned, even though the self-reported coffee intake is not perfect, the reproducibility and the validity of self-reported coffee intake is actually quite high. And in our cohorts, we found significant associations between self-reported coffee intake and the urinary concentrations of coffee metabolites, including caffeine and polyphenol metabolites from coffee. And also, some cohorts like ours have collected repeated measures of diet, which can reduce measurement error and capture long-term habits. And also, compared to other observational study designs like case control studies or cross-sectional analysis, large prospective cohorts can reduce reverse causation, recall bias, and selection bias. And in more recent studies, genetic biomarkers or plasma urinary metabolomics biomarkers have been incorporated into epidemiological analysis. And those studies have provided further support for the biological plausibility of the findings from the traditional epidemiological analysis. And we know that genetic variation can influence individuals' coffee consumption habits. In the genome-wide association analysis of more than 120,000 coffee consumers, several genetic variants have been identified to be associated with coffee consumption. And those genetic variants are related to caffeine metabolism, psychoactive effects of caffeine, and also metabolic traits. And the genetic variants explain relatively small variation in coffee drinking behavior in the population, but for individuals, those genetic variants can make a big difference in terms of individuals' coffee consumption behaviors. So the variability in caffeine metabolism is largely due to this gene, P1A2 genetic variants. So some people carry slow caffeine metabolism genotypes, others carry fast caffeine metabolism genotypes. There is some evidence that caffeine may have adverse cardiovascular effects in individuals who carry slower caffeine metabolism genotypes. For example, one study found that alleles for slow caffeine metabolism was associated with increased risk of hypertension compared with those who carry fast caffeine metabolism genotypes. However, this kind of findings need to be replicated in additional clinical and epidemiological studies. And as I mentioned earlier, in the UK Biobank study, caffeine metabolism genotypes did not influence the relationship between coffee consumption and lower risk of mortality. Based on the current evidence, the 2015-2020 dietary guidelines for Americans recommend that moderate coffee consumption, 3 to 5 8-ounce cups per day, up to 400 milligram of caffeine can be incorporated into a healthy eating pattern. But people who do not already consume caffeinated coffee are not encouraged to start drinking coffee to obtain healthy effects. So I think the message from the dietary guidelines is that for people who are already drinking coffee, there is no need to be concerned about harmful effects of coffee on chronic disease outcomes. But for people who don't already drinking caffeinated coffee for various reasons, there is no compelling reason for them to start drinking coffee to obtain potential health benefits. Of course, the amount of sugar and dairy added to coffee can make a difference in terms of the amount of calories added to the beverage or to the overall diet. And in most of the epidemiological studies, the analysis was typically based on coffee that is black or with little milk or sugar. And it's possible that adding too much sugar and calories may actually dilute the potential beneficial effects of coffee. And also, the serving size is important. So in epidemiological studies, 1 cup of coffee is 8 ounces with about 100 to 150 milligram caffeine. But if you get Starbucks grande coffee, it's going to be 16 ounces and more than 300 milligram of caffeine. So it's very important to be mindful about the portion size. So in summary, coffee consumption has been associated with numerous beneficial health outcomes, including decreased mortality risk. Moderate coffee consumption can be included as part of a healthy diet. However, many people still try to cut back on coffee to improve health, but they would be better off focused on other health, other lifestyle factors. So what other lifestyle factors can make even bigger differences in terms of chronic disease risk reduction and longevity? So recently we published a paper in Circulation look at impact of healthy lifestyle factors other than coffee on life expectancies in the US population. So in this study, we considered 5 diet and lifestyle factors, being physically active at least half hour per day of moderate to vigorous exercise, not smoking, light to moderate alcohol consumption, eating a relatively healthy diet, and maintaining a healthy weight. So those are the 5 low-risk lifestyle factors that we analyzed in this study. To calculate life expectancies, we use data from 3 sources, including age and specific mortality rate from the CDC, the prevalence of the 5 lifestyle factors from the enhanced data, and the associations between the lifestyle factors and mortality from the Nurses' Health Study and the health professional follow-up study. So this table shows the associations between the 5 low-risk lifestyle factors and total mortality, cancer, and CVD mortality. So as the number of low-risk lifestyle factors increase, there is progressive reduction in total mortality, cancer mortality, and CVD mortality. So for example, compared to those who did not have any of those 5 low-risk lifestyle factors, participants who had all the 5 low-risk lifestyle factors had almost 70% reduction in total mortality, 65% reduction in cancer mortality, and more than 80% reduction in CVD mortality. This figure shows estimated life expectancy at age 50 according to number of low-risk lifestyle factors. So this for women who did not have any of those 5 low-risk factors at age 50, the life expectancy is 29 years old. However, for women who had all the 5 low-risk lifestyle factors, the life expectancy at age 50 is 43 years old. So there is 14-year life expectancy difference at age 50 for those who followed all the 5 low-risk lifestyle factors compared to those who did not follow any of those low-risk lifestyle factors. For men, the difference is about 8 years. So this analysis indicated that adherence to the low-risk lifestyle factors can substantially improve overall life expectancy. Unfortunately, in the US population, the average number of low-risk following the low-risk lifestyle factors is pretty low. So that the average number is less than 2. So it means that from public health point of view, we still have a long way to go in terms of improving the lifestyle factors for reducing chronic diseases and increasing life expectancy of the overall population. And recently, we updated analysis by looking at healthy lifestyle factors and life expectancy free of major chronic diseases, including cancer, CVD, and type 2 diabetes. This study was published in BMJ last year. So in the circulation paper, we calculate total life expectancy. And in this paper, we calculated life expectancy free of major chronic diseases. And we found that adherence to a healthy lifestyle at middle age is associated with a longer life expectancy free of major chronic diseases. So it means that a healthy lifestyle not only improve overall longevity, but also healthy longevity or the health span of the individuals. For example, a 50-year-old woman with at least 4 of the 5 low-risk habits could expect to live to age 84 before getting cancer, CVD, or type 2 diabetes. In contrast, a woman with none of the low-risk habits could expect to live to age 74 without those diseases. So this is a 10-year life expectancy differences between the 2 groups of women. For men, a low-risk man could expect to live disease-free to age 81 rather than age 74. So it's a 7-year disease-free life expectancy difference based on the lifestyle factors. And when we look at the individual risk factors, not surprisingly, cigarette smoking substantially reduce disease-free life expectancies for both men and women. For body weight, looks like there is a U-shaped relationship. So being underweight and being obese associated with reduction in disease-free life expectancies. For alcohol, it's also a U-shaped relationship. Long drinkers and heavy drinkers tend to have lower disease-free life expectancies. Light to moderate drinking is associated with higher disease-free life expectancies in both men and women. For diet, the higher the diet quality, the greater disease-free life expectancies. So there is a dose-response relationship between increasing diet quality and increasing longevity. And exercise, not surprisingly, is also a dose-response relationship. So for men and women who exercise about half hour to 1 hour per day, they had significantly increased disease-free life expectancies. So one of the important factors is diet quality. It's very difficult to assess diet quality in free living populations. And in this study, we used alternative healthy eating index to assess diet quality, but that's much more, that's not feasible in clinical practice. And this is a simplified version of alternative healthy eating index based on self-reported intake of several major food groups, fruits and vegetables, whole grains, sugary drinks, nuts, beans, red and processed meat, and seafood. So based on self-reported intake of those foods, you can calculate a rough estimate of diet quality for individuals. So in summary, coffee consumption has been associated with a wide range of beneficial health outcomes, and it can be included as part of healthy diet and lifestyle, but certainly coffee is not a magic bullet. We found that adherence to low-risk lifestyle, including eating a healthy diet, being physically active, not smoking, and light to moderate alcohol consumption could prolong life expectancy at age 50 by 14 years in US women and 12 years in US men, as compared to individuals without any of the low-risk lifestyle factors. And most of the years saved are free of chronic diseases. So it means that the low-risk lifestyle not only increase overall longevity, but also increase the quality of life for individuals. And the gap in life expectancy between US and other developed countries can be narrowed by improving lifestyle factors. And finally, of course, we need policy changes to improve our food and built environment to make healthy choices easier, accessible, affordable, and normative. So I'm going to stop here. Thank you very much for your attention. I would be happy to take any questions.
Great, thank you. So we have a couple of questions in the chat box, and everyone feel free to add to that if you have any. The first question is from Dr. Coben, who's wondering about the confounding effects of some of the studies that you presented, especially the nurses' health study. Since these findings are based on questionnaires that are sent to participants, she's mentioning the possibility of recall bias. That the nurses' health study in particular has been associated with a quote, healthy woman bias. Has this one, or other studies, have they been adjusted for BMI, cholesterol profiles, intake of other nutrients? I think you already presented some of that data.
Right. Yeah. So let me answer this question first. In all this analysis, potential confounding factors, including BMI, smoking, family history of chronic diseases, other dietary factors were adjusted for. So the main issue is residual confounding. As I mentioned earlier, it's impossible to completely rule out residual confounding in any observational analysis. But because coffee consumption is actually associated with unhealthy diet and lifestyle, so in our cohorts, for example, women who drink a lot of coffee tend to have higher BMI, tend to smoke, and tend to have unhealthy eating habits. So adjustment for those factors actually make the inverse association stronger. So this is different from other type of studies where you find inverse association, for example, between vegetable consumption and mortality, and the confounding may explain this inverse association. But for coffee, it's actually the opposite. The confounding factors actually mask or obscure the inverse association between coffee consumption and the various health outcomes. So again, I don't think confounding is a potential explanation for this type of findings. And also in prospective cohort studies, coffee consumption was assessed prior to the development of chronic diseases. So it means that recall or the self-reported coffee consumption is not influenced by the disease status, which may typically occur in case control studies. So recall bias is unlikely to be explanation for this type of findings either.
Okay, understood. All right, so it looks like that's it for our chat box. If anybody has any additional questions, feel free to either type them in or unmute yourselves and go ahead and ask.
Dr. Reed, thank you for your wonderful presentation. I had a question with regard, one of the, in practice, some of the common reasons that patients come in and are advised to stop drinking coffee with gastroesophageal reflux disease or atrial fibrillation, which your studies have shown don't seem to associate with coffee at all. But maybe they do in the so-called slow metabolizing group or so. Is there a way to diagnose those who are slow metabolizers of caffeine, or? Yeah,
it's very easy to I guess test whether an individual is a fast metabolizer or slow metabolizer. You can easily do genetic testing by sending the saliva samples to 23andMe, and the genetic test results will show whether you carry the fast metabolite genotype or slow metabolite genotype. I think your point about AFib and reflux, I think it's interesting because if you look at, population-based studies, overall, it looks like coffee doesn't appear to have appreciable effects. And the issue is that whether individuals may have variations in their response to coffee or caffeine. And besides the genetic background, I think it's also useful, of course, to measure some of the metabolites related to their response to coffee or caffeine. Of course, clinically, that's going to be much more difficult. Nevertheless, I think the genetic testing is very accessible and very easy to do.
So we'll probably end with this question. Dr. Kim is asking, can you comment on the risk of fracture or osteoporosis with coffee consumption? And thank you for a wonderful presentation.
Well, for fractures, I think there is some evidence that higher caffeine consumption is associated with increased fracture. But the evidence, I think, is not very consistent, not very convincing. And this is the area I think we need more research in terms of both clinical studies and large-scale epidemiological studies. I didn't have time to talk about bone-related health outcomes. I think that's an area certainly deserve more research and more careful analysis in large cohorts.
Great. Okay. Thank you so much.
Okay, thank you. I hope you are enjoying your coffee and the rest of the day. Thank you.
Take
Bye.
care. Thank you.